If you take amlodipine every day and you have been told the main side effects to watch for are swollen ankles and occasional headaches, you have been given an incomplete picture. The swollen ankles are real, the headaches are real, but there is something else happening inside the body of a senior on long-term amlodipine that most prescribing physicians never bring up, not because they are hiding it, but because it unfolds gradually over months and years in ways that do not fit neatly into a 10-minute follow-up appointment. It disguises itself as something else. It gets blamed on aging, on other conditions, on other medications. It affects quality of life in ways that are quietly significant, and it is entirely manageable once someone explains what is actually happening and why. By the end of this video, you will understand exactly what amlodipine is doing inside blood vessels, kidneys, and surrounding tissues over years of daily use. You will know the side effects that are listed on the package insert and why those descriptions are so clinical, they fail to prepare patients for the actual experience. You will know the side effects that are almost never discussed, the ones that show up in cardiology consultations, in nursing home assessments, in geriatric medication reviews, years after the drug was first prescribed. You will understand who is most vulnerable, what to monitor, when something warrants a phone call versus an emergency room visit, and what options exist when amlodipine side effects are genuinely interfering with life. Before we begin, I want to say this directly. Amlodipine is one of the most prescribed medications in the world, for good reason. It is effective, it is well tolerated by most people, it lowers blood pressure reliably, it reduces angina, it has decades of outcome data showing it saves lives and prevents strokes. This is not a video asking you to be afraid of your prescription. It is a video about understanding what your prescription is doing over time. Because the safest patients are not the ones who simply take the pill. They are the ones who know what the pill is doing, what to watch for, and when to have a conversation their doctor might not be initiating on their own. Let us start with the mechanism, because once you understand how amlodipine works, the side effects stop feeling random and start making physiological sense. Amlodipine is a calcium channel blocker, specifically a dihydropyridine calcium channel blocker, which means it primarily acts on the smooth muscle cells inside blood vessel walls, rather than directly on the heart's electrical conduction system. Calcium is what allows smooth muscle cells to contract and tighten. When amlodipine blocks calcium from entering those cells, the muscles relax. Blood vessels dilate. They open wider. Blood flows through them with less resistance. The heart has to push against less pressure. Blood pressure falls. This selectivity for blood vessels over heart muscle is actually what makes amlodipine different from the other major calcium channel blocker family, the non-dihydropyridines like diltiazem and verapamil, which affect both blood vessels and the electrical conduction of the heart. Amlodipine's preference for vascular smooth muscle is a clinical advantage in many situations. It does not slow the heart rate the way diltiazem does. It does not depress cardiac contractility the way verapamil can, and it is generally safer to use in patients who already have a slower heart rate or some degree of heart block. But that same vascular selectivity means the drug's effects are concentrated in the peripheral circulation, in every blood vessel throughout the body, rather than being partially absorbed by heart rate changes that might soften the blood pressure response. Amlodipine is also distinctive among its class for its extremely long half-life, approximately 35 to 50 hours. This means the drug stays active in the body for a day and a half to 2 days after a single dose. It accumulates gradually over the first week or two of daily use until it reaches a steady state concentration, a plateau at which the amount entering the body each day equals the amount being metabolized and excreted. Once at steady state, the blood level changes very little from hour to hour within a day, which gives amlodipine its smooth, consistent blood pressure control, without the peaks and troughs seen with shorter-acting antihypertensives. But that same long half-life means that side effects, when they develop, are also persistent. There is no low-concentration window during the day when the vessel walls get a rest from the vasodilatory effect. The dilation is continuous. The consequences, however the body is experiencing them, are present at every hour. This mechanism is elegant and effective, But it does not happen only in the blood vessels your cardiologist is targeting. It happens in blood vessels throughout the body, including the tiny capillary networks that supply peripheral tissues: the skin, the legs, the feet, the gums, the face. And it happens continuously, every hour of every day, for as long as the drug is taken. The body does not get to choose which vessels relax and which stay at normal tone. Amlodipine tells them all to relax, and the body then spends the entire day managing the consequences of that broad vasodilation in tissues that were not the therapeutic target but are still fully exposed to the effect. This is the foundation from which virtually every significant side effect of amlodipine, including the ones that are almost never discussed, emerges. Not a malfunction of the drug, not an allergy, not a coincidence. A direct consequence of the precise mechanism that makes it therapeutically useful, expressing itself in tissues and systems beyond the ones being treated. The ankle swelling, peripheral edema, is the side effect most people know about, but most people have not had it properly explained to them, and that incomplete explanation is part of why it causes so much unnecessary alarm and so much unnecessary medication piling on top of it. When amlodipine relaxes blood vessel walls, it does so preferentially on the arterial side of the capillary network. The arterioles, the small vessels feeding blood into capillaries, relax and dilate. More blood flows in under less pressure. But the venules, the small vessels draining blood back out of capillaries on the venous side, do not relax as much. The inflow exceeds the outflow. Pressure builds in the capillary bed. Fluid is pushed out of the capillaries into the surrounding tissue. That fluid accumulates. In the legs and ankles, gravity pulls it downward, and by the end of the day, the feet are swollen, the socks have left marks on the skin, and the shoes feel tight in a way they did not in the morning. This is what most patients are told. You might get a little swelling in your ankles. What most patients are not told is why the mechanism means this swelling is not heart failure. It is not kidney failure. It is not liver disease. It is the pharmacology of the drug redistributing fluid into peripheral tissue. The distinction is not academic. It is the difference between a concerning new diagnosis and a manageable known side effect. And it matters enormously in an aging population because when an older adult presents to a doctor or emergency room with swollen ankles, the first thing the clinical mind reaches for is cardiac or renal pathology. If nobody knows the patient started or increased amlodipine 6 weeks ago, the workup can spiral into echocardiograms, kidney function panels, and, critically, a prescription for a diuretic to remove the fluid. This is what most patients are told. You might get a little swelling in your ankles. What most patients are not told is why the mechanism means this swelling is not heart failure. It is not kidney failure. It is not liver disease. It is the pharmacology of the drug redistributing fluid into peripheral tissue. The distinction is not academic. It is the difference between a concerning new diagnosis and a manageable known side effect. And it matters enormously in an aging population because when an older adult presents to a doctor or emergency room with swollen ankles, the first thing the clinical mind reaches for is cardiac or renal pathology. If nobody knows the patient started or increased amlodipine 6 weeks ago, the workup can spiral into echocardiograms, kidney function panels, and, critically, a prescription for a diuretic to remove the fluid. Before getting to why that diuretic can be dangerous, it is worth understanding why peripheral edema from amlodipine is significantly more common and more severe in women than in men, and why it worsens with age in ways that younger patients on the same medication often do not experience. Women have a higher proportion of body fat relative to lean muscle mass than men, on average, and fat tissue has a higher proportion of extracellular fluid compartment than muscle. This means that the same degree of capillary leak from amlodipine results in more visible and more symptomatic swelling in women. Additionally, venous tone, the ability of the veins in the legs to propel blood back up to the heart against gravity, declines with age and is generally lower in women than in men. When amlodipine's arterial dilation is layered on top of already reduced venous return in an older woman, the fluid that accumulates in the legs has fewer mechanisms to drain itself. It sits. By evening, it is visibly swollen. By the next morning, after a night of lying flat, it has redistributed back and the morning looks almost normal, leading some patients and physicians to underestimate the burden because the ankles look different at a daytime appointment than they do at 7 in the evening. The nocturnal redistribution of that accumulated leg fluid has its own clinical consequence that is rarely discussed. When a patient has been upright all day and significant fluid has pooled in the legs, lying down to sleep allows gravity to release that fluid back into the central circulation. Blood volume in the chest and heart increases. In patients with any degree of underlying heart dysfunction or reduced cardiac reserve, this fluid shift can worsen shortness of breath at night, a phenomenon called orthopnea or paroxysmal nocturnal dyspnea. The patient who wakes at 2 in the morning unable to breathe comfortably, who finds they need to prop themselves on 2 or 3 pillows to sleep, this can be amlodipine's edema redistributing overnight rather than primary heart failure progressing. The distinction is critical and requires a physician's assessment, but it is a distinction that is more likely to be made correctly when the patient and physician both know that amlodipine is in the picture. That diuretic prescription is the beginning of what some clinicians call a prescribing cascade. One drug causes a side effect. The side effect is mistaken for a new disease. A second drug is prescribed to treat the first drug's side effect. The new diuretic, hydrochlorothiazide or furosemide sold as Lasix at most pharmacies, or spironolactone, reduces the fluid volume in circulation. That reduced volume, combined with the vasodilation already being produced by the amlodipine, can push blood pressure further down than intended and cause episodes of dizziness on standing, weakness, and in seniors with impaired balance reflexes, falls. Now there is a fall to manage, which may lead to further medication changes, restrictions on mobility, and a loss of independence, all originating from a side effect that could have been managed far more simply if someone had asked when the swelling started and what medication was started around the same time. Let me tell you about Loretta, 74, who had been on amlodipine 5 milligrams for 8 months when she first noticed that her ankles looked different in the evening, not dramatically swollen, just thicker, heavier, puffy in a way she had not seen before. She said nothing for 3 months because she assumed it was her heart and was afraid of what that might mean. When she finally told her primary care physician, the doctor ordered an echocardiogram, a renal function panel, and a BNP, a blood test that measures a cardiac stress hormone. All normal. A diuretic, hydrochlorothiazide 12.5 milligrams, was added. The swelling improved, but Loretta started having episodes of feeling faint in the morning when she stood up from bed. One morning, she stood up too quickly, felt the room tilt, grabbed the bedpost, and her hand slipped. She fell. She did not break anything. She was lucky. When a geriatrician reviewed her medication list, the connection was made immediately. Amlodipine-induced peripheral edema being treated with a diuretic in a 74-year-old whose blood pressure was already well controlled. The hydrochlorothiazide was discontinued. The amlodipine dose was reduced from 5 milligrams to 2.5 milligrams, a dose not available as a standard tablet but achievable by splitting the 5 milligram tablet with a pill splitter. The swelling became manageable. The dizziness resolved. Loretta had not needed a second medication. She had needed an explanation. Now let us talk about the side effect that the title of this video is pointing to, the one that most seniors on amlodipine have never been told about. It appears in clinical literature. It has a clinical name, it has a well-understood mechanism, and in some patients, it causes more daily distress than any other consequence of the drug. It is gingival hyperplasia, the overgrowth of gum tissue. Calcium channel blockers as a class are among the most established pharmacological causes of drug-induced gingival overgrowth. The phenomenon has been documented extensively since the 1980s when calcium channel blockers first became widely used. The mechanism involves the drug interfering with calcium-dependent pathways in gingival fibroblasts, the cells responsible for maintaining connective tissue in the gums. When calcium signaling is disrupted in those fibroblasts, they overproduce collagen. The gum tissue thickens. It grows over the teeth in a way that is painless initially and therefore unnoticed. until brushing becomes uncomfortable, until the gums bleed more easily during dental cleaning, until the tissue has grown enough to change how food sits in the mouth or how the teeth feel when biting. Among calcium channel blockers, nifedipine has the highest reported rate of gingival hyperplasia. Some studies report it in up to 50% of patients. Amlodipine's rate is lower. Estimates range from 1 to 3% in the published literature, though some studies suggest higher rates in patients with poor oral hygiene baseline. That lower percentage does not make it a negligible concern in a country where tens of millions of seniors are taking amlodipine daily. 1 to 3% of tens of millions is a large number of people walking around with drug-induced gum changes that nobody connected to their blood pressure medication. The timeline of gingival hyperplasia matters because it explains why so many patients and clinicians miss it. Changes typically begin within 3 to 12 months of starting amlodipine, but they develop so gradually that the difference between the gum tissue at month 2 and month 8 is nearly imperceptible without specific attention. The tissue does not suddenly swell overnight. It inches forward over the teeth slowly, first becoming slightly fuller and firmer at the gum margin, then beginning to extend downward over the tooth surface in a way that creates deeper crevices between gum and tooth. By the time a patient notices something is different, months of progressive change have already occurred. Early-stage changes are smooth and pink rather than red and inflamed. They do not look obviously diseased, which is another reason they go unrecognized. Late-stage changes, if untreated, can result in tissue that covers a significant portion of the visible tooth crown, making oral hygiene nearly impossible and creating the exact environment for accelerated periodontal disease. What makes this side effect particularly damaging for seniors is how it interacts with existing oral health vulnerabilities. Seniors are already disproportionately affected by periodontal disease, gum disease driven by bacterial inflammation that erodes the bone and tissue supporting the teeth. Amlodipine-induced gingival hyperplasia creates enlarged tissue with deeper pockets between teeth and gums where bacteria accumulate more easily and are harder to clean. This promotes periodontal infection. Periodontal infection increases systemic inflammatory markers. Elevated systemic inflammation drives vascular endothelial dysfunction. Endothelial dysfunction worsens blood pressure control and cardiovascular risk. So, the drug prescribed to protect the cardiovascular system can, through this oral pathway in susceptible patients, undermine the very cardiovascular health it was intended to support. Let me tell you about Morris, 68, who had been on amlodipine 10 milligrams for 4 years when he noticed that his gum line looked different in photographs. He described it as the gums having grown toward the teeth in a way that made his smile look different. He assumed it was age. He assumed it was something his dentist had missed. At his next dental cleaning, the hygienist noted significant tissue overgrowth and referred him to a periodontist. The periodontist recognized the pattern immediately and asked Morris whether he was on a calcium channel blocker. He was. Nobody had told him this was possible. The periodontist contacted his prescribing cardiologist, who was open to discussion. Morris was switched from amlodipine to a different antihypertensive class, specifically an ARB, irbesartan 150 milligrams once daily, available by prescription at most pharmacies under the brand name Avapro for significantly more than the generic, or as generic irbesartan for approximately $15 to $25 per month, with equivalent blood pressure control. Over 6 to 12 months following the switch, with rigorous dental hygiene and professional cleaning every 3 months, the gingival overgrowth partially reversed. It did not return to fully normal because some of the fibrous tissue change is permanent once it has been present for years. Morris wished, retroactively, that someone had told him to watch for this in the first year. The early changes are far more reversible than the changes after 4 years. The lesson is not that amlodipine causes gum disease in everyone. It does not. But it is that any senior taking amlodipine who notices gum tissue changes, thickening, bleeding that is new or worsening, changes in the way the teeth feel or the way the mouth functions, should bring that observation to both their dentist and their prescribing physician. Not in separate conversations that never cross paths, but in a connected discussion about whether the medication might be the cause. Excellent oral hygiene reduces the risk. Twice daily brushing with a soft toothbrush, daily flossing, and professional dental cleanings every 3 to 4 months, rather than the standard 6, are the most evidence-supported mitigation strategies for patients who need to remain on amlodipine. The next under-discussed side effect is heat intolerance and flushing. And this one affects daily quality of life in ways that seniors frequently attribute to their age, to menopause history, to anxiety, or to something wrong with their thermoregulation, without ever connecting it to the pill they take every morning. Amlodipine causes widespread vasodilation. When peripheral blood vessels dilate, blood redistributes toward the skin surface. The skin feels warmer. Flushing, a sensation of warmth, redness, or heat in the face and upper chest, is a direct consequence of cutaneous vasodilation. In warm weather, in a warm room, after a meal, after mild exertion, or after a hot shower, that already dilated peripheral circulation dilates further in response to temperature, amplifying the flush, the sweating, and the sensation of overheating to a degree that many seniors find distressing and exhausting. This is not dangerous in itself, but it is profoundly uncomfortable for people who experience it consistently, and it contributes to behavior changes that have downstream health consequences. Seniors who are always too warm avoid going outside in summer, avoid social gatherings in warm rooms, reduce their physical activity because exertion feels immediately overwhelming, and in some cases develop heat exhaustion because their body's ability to further dilate vessels in response to heat is already maxed out by the medication. Heat exhaustion in an older adult can precipitate dehydration, electrolyte imbalance, and a blood pressure drop that compounds the orthostatic hypotension risk already created by the drug. The drug's peak vasodilatory effect occurs 6 to 9 hours after the morning dose for most patients, which for someone taking amlodipine at 8 in the morning means the strongest flushing and heat sensitivity is typically in the early to mid-afternoon. Some patients manage this by timing outdoor activity or exertion for early morning before the peak effect, or by shifting the dose to evening, a strategy that should always be discussed with the prescribing physician rather than implemented independently, because timing changes can affect blood pressure coverage at specific windows and interact differently with other medications. Let me tell you about Eleanor, 71, who had been on amlodipine 5 milligrams for 2 years. She described her experience as feeling permanently overheated. She had stopped going to her Tuesday afternoon walking group because she said she looked red and flushed before she had even walked a block, felt dizzy by the end of the first 10 minutes, and was embarrassed by how she looked and felt compared to her peers. She had seen her doctor about the flushing and been told it was likely menopause-related vasomotor symptoms. She was postmenopausal and had been offered hormone-related options she did not want to pursue. Nobody asked when the flushing had started. Nobody compared the timeline of the flushing to the timeline of the amlodipine prescription. When the connection was finally made by a cardiovascular nurse practitioner reviewing Eleanor's complete medication history, the amlodipine dose was reduced from 5 milligrams to 2.5 milligrams with physician agreement. The flushing reduced substantially. Eleanor returned to her walking group. The indirect health benefit, restored physical activity, restored social connection, restored quality of life, was not captured anywhere in her medical record, but it was entirely real. The cardiovascular consequences of reduced physical activity in seniors are profound. Deconditioning occurs rapidly in older adults. Muscle mass declines, balance worsens, metabolic health deteriorates. Blood pressure regulation, paradoxically, becomes harder without the benefit of regular aerobic exercise, a medication side effect that drives someone away from the physical activity that was protecting their heart is doing real harm, even if no individual appointment flag would capture it. Reflex tachycardia is another amlodipine effect that surprises patients because it seems counterintuitive. When blood vessels dilate broadly, blood pressure initially drops. The body, detecting that drop through its baroreceptors, responds by increasing the heart rate to compensate. The heart beats faster to push more blood through the system and restore adequate pressure. This reflex response is normal physiology, but in the context of a drug being taken specifically for cardiovascular reasons, the sensation of a faster, more prominent heartbeat can be alarming to a patient who is not warned to expect it. In most patients, this reflex is mild and the heart rate increase is modest, perhaps 5 to 10 beats per minute above baseline. In some patients, particularly those on amlodipine alone, without a heart rate slowing companion medication like a beta blocker or a rate-limiting calcium channel blocker like diltiazem, the heart rate may run consistently higher than before treatment began. Seniors who notice that their heart seems to be beating more prominently or more frequently after starting or increasing amlodipine, a sensation often described as being able to feel the heartbeat in the chest at rest or feeling the pulse in the ears or neck, are experiencing this reflex. It is not usually dangerous, but it is not nothing, and it is not something to normalize without mentioning it. When persistent and bothersome, reflex tachycardia from amlodipine is often the rationale for adding a low dose of a beta blocker. Metoprolol succinate, available generically and as Toprol XL at most pharmacies for approximately $10 to $20 per month to the medication regimen. The beta blocker slows the heart rate and smooths the compensatory reflex, often improving how the patient feels substantially. This is a clinically sensible combination, but it is a second medication added because of a side effect of the first. And the patient deserves to understand that narrative rather than simply receiving a new prescription without context. Fatigue is among the most reported but least clinically acknowledged side effects of long-term amlodipine use in seniors. Patients describe it in various ways: feeling more tired than they used to be, needing to rest more during the day, losing stamina that they had before the medication started, finding that tasks that used to be easy now feel effortful. They attribute it to getting older, to poor sleep, to the other health conditions they are managing. Their doctors, reviewing a blood pressure that is under control and an echocardiogram that is stable, see nothing in the clinical data to explain the fatigue and attribute it to the same things. The mechanism is not fully characterized, but likely involves several overlapping factors. Broad peripheral vasodilation reduces the pressure driving blood to working muscles during activity, muscles that require adequate perfusion to sustain effort. The reflex tachycardia that keeps blood pressure adequate at rest may not fully compensate during exertion, creating a gap between effort and blood flow that manifests as early fatigue. In some patients, blood pressure that is lowered more than necessary because the dose chosen was calibrated to a blood pressure that has since improved with lifestyle changes, or because the body has become more sensitive to the drug over time, means tissues are chronically underperfused relative to what they previously experienced. A body accustomed to years of higher pressure operating at a significantly lower pressure may take months or years to fully remodel and adapt, during which fatigue is the symptom that represents that adjustment. There is also a kidney perfusion dimension to fatigue in overtreated hypertension that is worth understanding. When blood pressure is maintained substantially below historical levels, the kidneys, which are highly pressure-sensitive organs that depend on adequate perfusion pressure to maintain their filtration rate, may respond with a mild reduction in glomerular filtration. This manifests on blood tests as a modest rise in creatinine, often dismissed as unremarkable in an aging patient. But a kidney that is filtering less efficiently also produces less erythropoietin, the hormone that stimulates red blood cell production in bone marrow. Subtle reductions in red blood cell mass, not dramatic enough to be classified as anemia on standard thresholds, but meaningful relative to the individual's personal baseline, reduce the oxygen-carrying capacity of the blood. Less oxygen delivered to working muscle is fatigue, not imagined fatigue, not age, not depression. Physiological fatigue with a traceable mechanism rooted in a blood pressure being kept lower than the body is currently best served by. This is clinically important because fatigue in older adults is the beginning of a downward spiral that clinicians recognize and dread. Fatigue leads to reduced activity. Reduced activity leads to muscle loss, sarcopenia, which in seniors accelerates over surprisingly short periods of inactivity. Sarcopenia worsens balance and fall risk. It worsens metabolic health and insulin sensitivity. It worsens quality of life, functional independence, and cognitive engagement. If a medication side effect is the trigger for that spiral, identifying and addressing it is not a cosmetic concern. It is a major health priority.